All right, welcome back everyone to another virtual shouting session at Hearts for Health. We're glad that you could catch us this week for another session. Today, we're joined by Dr. Asif. He's a transplant hepatology fellow at the Mayo Clinic in Rochester, Minnesota. So I'm very excited for this session. I know that y'all are too. This is one that we were looking forward to. I do have a few reminders for y'all, especially if you are new. So if you're just unfamiliar with our structure to virtual shadowing, how our sessions typically run is we have speakers from different specialties. We have them in medicine, in dentistry. We have PAs, we have nurse practitioners, because we know that there's a few pre-PA, pre-dental, et cetera, students out there. So we have a pretty good variety of speakers, of backgrounds. And with each session at the very end, we do have a Q&A. You'll see a chat box either to the right or below this live stream here. So if you have any questions for Dr. Asif, please feel free to go ahead, type them in the chat, and we'll get around to them at the very end in the order that we receive them. Also, for those who want to stay tuned with our sessions, we do have multiple sessions a week, typically 2 on Mondays and Thursdays. So just to keep in touch with us over those, we have our Instagram page, which is likely how a lot of you have heard of us. We have flyers on there that we post. And then we also have our email listserv, which is basically the same thing. It's a weekly email with those flyers attached and also a couple other opportunities. But we typically have those same opportunities on our Instagram, but there sometimes are some additional opportunities that we just include on our listserv because of them being just a little too minor for Instagram. So that's one way to get in touch with us, the Instagram page, and then the other is the email listserv. To get added onto our email listserv, you can either email us at community.h4h@gmail.com, or you can go onto our website, hearts4health.org. Go to the very bottom of any page, and on the left, you'll see a subscription form. You can subscribe that way. That way you can hear from us through weekly emails. One thing I do want to say, though, is around this time of year, we're going to have a mid-semester break. So between this session, after this session, I should say, and March 13th specifically, we're going to have a mid-semester break, and we'll resume shadowing sessions on March 13th. So be sure to look out for that. We will be posting our flyers accordingly once those sessions roll around. But I don't want to take up too much time, so Dr. Asif, feel free to take it away.
Thank you. Good evening, everybody. Thank you so much for coming to hear me speak today. Special thank you to Michael and the rest of the team at Hearts for Health for giving me the opportunity to talk at today's virtual shadowing program. It's funny, when I was first looking into applying to med school, I wish I had something like this to really help me navigate some of the intricacies, to really promote kind of accessibility and figure out opportunities. So I'm really happy that there are institutions like you guys have started to help students get insight into different experiences in healthcare. So as Michael mentioned, I am a transplant hepatology fellow at the Mayo Clinic in Rochester, Minnesota. And today I'm going to be talking about overall my journey through medicine, and then more details into liver disease and a few cases to finish off, to make sure we have a good, well-rounded session. A little bit of an introduction for me. Michael already kind of gave a bit of a background, but I was born and raised in New York City, traveled a few different areas across the country for my training. I'm currently in my last year of training, 7th year, so I'm pretty excited to be done in a few months. A fun fact about me is that I am an amateur yard, so I do enjoy doing that in my free time. My professional interests from a medical perspective include alcohol-related liver disease, medical education in all its forms, especially leveraging technology to help students learn the way they need to. And then immigrant health across all areas of medicine, but specifically when it comes to liver disease and disparities in those communities. So without further ado, here's kind of an overview of what I wanted to talk about. I know we're scheduled for about an hour and a half today, and I want to have some time at the end for questions that you may have. So today's talk will largely be divided up into 2 main sections. In the first one, I'm going to walk everybody through kind of my journey through medicine, through healthcare, and what I learned along the way about becoming a doctor. Starting off with, what exactly does a liver doctor do? In the second part, we're going to be talking about clinical cases within liver disease and patients who may need a liver transplant. We'll talk about the more common reasons why people do have problems with the liver and why it actually matters to focus on liver disease as a community, as a country, and as the world contends with a lot of different medical issues going on. So I often get asked, pretty often, what is a hepatologist and what do they actually do? And I think it's a really important question because to the layperson, it's not very obvious. And at least when I was a pre-med student, it wasn't obvious to me what exactly a hepatologist does. I had some interactions with those individuals in college while shadowing, but I didn't really exactly know. So I'll start off with explaining a little bit about the pathway. So to become a hepatologist, you do actually, after medical school, do a 3-year residency in internal medicine. Um, Generally afterwards, people do a 3-year fellowship in gastroenterology, and that is focusing on all sorts of diseases of the GI tract, one of which being the liver. And then most people end up doing an additional year, a second fellowship in transplant hepatology, which really focuses much more on liver disease specifically. Um, Over the past 5 to 10 years, this extra year has been added on as liver disease has gotten to become much more specific. And the community realized it was actually pretty important to have more specialized training. The burden of liver disease, as I'll talk about later on in the presentation, is pretty massive across the country, if not the world. And different areas of the world actually have very different kind of subsets of liver disease populations that people have to contend with. Overall, uh, individuals who are hepatologists treat disorders of the liver, the gallbladder, and the bile duct. On the right side is a very nice image. The top left shows where the liver is in the abdomen, in the right upper side. Underneath the liver, on the right side, you can see that the gallbladder is kind of nestled in underneath there in the green. And the green little tubes are the bile duct systems. I'll talk about those a little bit more in detail. All these systems work together, the liver, the gallbladder, and the bile duct work together to promote different areas of our health and interact really closely with other organs in the intestine. More specifically, after we talk about treating disorders of liver disease, hepatologists, in addition, do perform liver biopsies, though that is something that is starting to fade away as there are becoming safer ways to do liver biopsies. A lot of those procedures are now either going to interventional radiologists to do it through blood vessels inside the neck, or endoscopists who actually do it through the walls of the stomach or the intestine. Those are actually much safer procedures, less risk of complications. And so the field as a whole, I think, is trending toward those less invasive procedures. Because most hepatologists are gastroenterologists by training, we do perform endoscopies and colonoscopies, and that means looking at the inside of people's stomach, esophaguses, intestines, as well as large intestines, both looking for things like bleeding, cancer, and other kind of abnormalities. And finally, the big reason why the separate year of hepatology training is warranted is because there is a need for liver transplantation for multiple disease processes. And so that specific focus requires a bit more dedicated care because it does become complicated and there are actually not enough liver providers across the country. And we'll talk about that a little bit later. So I'm going to use this as kind of a broad outline for what my path from high school into undergrad all the way to where I am right now, which is looking for a faculty position, has been. And it kind of goes through all these stages, and I'll kind of discuss what I felt at each stage, what I learned about medicine, and how it kind of shaped my decisions going forward overall. We'll start off with college. I went to undergrad at Stony Brook University, which is in the suburbs of New York City. I focused on psychology as my major. When I got to college, I didn't exactly 100% know what I wanted to do, but I knew a few things about what I was interested in. I knew I liked science. I knew I liked psychology. I had taken a few elective classes within high school during my senior year, AP and IB classes in psychology. And I really, really enjoyed understanding human behavior and why people did the way they did, even if it didn't make sense necessarily. And I knew I liked solving problems to some extent. And so going into college, that was kind of my big focus. I wanted to see if psychology could be something I could be interested in. I explored a lot of different things while I was in undergrad. I wanted to focus on something that gave me a good breadth. Medicine had been an underlying backbone of what I wanted to focus on, but I wanted to get a good grounding overall. I was lucky to have really excellent mentors in my undergrad experience. And so I joined a research lab fairly early on, focusing on neuropsychology and emotion regulation. And we did a bunch of different studies focusing on functional MRI technologies, looking at how people reacted to stress stimuli in different settings. And that really helped me understand how research worked in a institutional manner, what it involved to investigate human behavior, human disease in a very systematic way, and it made it much more real. Alongside research and obviously the classes I was taking, I did try to focus on extracurricular activities. Because my major was psychology, I was able to really hone in on psychology-focused interest groups. I ended up leading one of the psychology honor societies on campus, and we did a lot of different events. And it not only cemented my desire later on to do medicine, but I think it brought another factor, another layer to how I viewed medicine, because it made me realize that medicine actually actualized the humanities and made people come to life. And knowing both sides really helped me understand what I enjoyed and what I wanted to do. Alongside the extracurriculars and the research, like I mentioned, I did want to make sure that I had some medical experience to know whether medical school was something I wanted to pursue. So I did shadow in different departments within the hospital at Stony Brook, which had actually its own hospital across the street from the undergraduate campus. All those things together, I think, were very instrumental in figuring out what I wanted to do. As I went to med school, which incidentally was at the same institution, again across the street, I wanted to keep an open mind initially. I did know I enjoyed research from my undergrad, and I wanted to continue that in some fashion. I did not think I wanted to continue in the same realm, but the idea of kind of investigating things I didn't know about and having a very systematic approach to it is something that was very, very important to me. I did look at a few different projects that were available to medical students at the time. I connected with one of my mentors, Dr. Richard Clark. And so with him, I actually worked in his lab for about 3 years and I was in med school, looking at research in wound healing and burn injury in pig models. And that was basically transferable to patients who have burn injuries. And we looked at a lot of different case series. And I was happily able to publish on that later on during med school. Med school itself is hard enough, as anybody will tell you who's been through it. It's very busy with a lot of lectures, a lot of tests, and in the past 10 years or so, medical education has changed a lot, and I will talk about that a little bit later. The model I had when I went to med school was, out of the 4 years, the first two were what we call kind of the basic science or didactic sessions, where they focused on the fundamentals of the sciences. So we had classes in anatomy and biochemistry, as well as neuroscience, and then we had organ system specific classes. In addition to that, in third and fourth year, we focused on clinical rotations, and that was the majority of the third and fourth year. And by the end of the third year, you tend to kind of had to figure out what you wanted to do and focus in on that, because the fourth year is really kind of focused on doing electives in the area you were interested in, making sure you had appropriate connections and letters of recommendations for individuals in the field, and also that you would be happy in the field that you chose. A lot of that ended up being supplemented by mentoring I had on the side from physicians I had either worked with during my clinical rotations or that I had managed to be in contact with early on in medical school. I did want to make sure I had a well-rounded experience in med school. And so in addition to classes and research, like I mentioned, we had a fairly active Asian Pacific American Medical Student Association at my medical school. And so we were very active during my first and second years, a little bit less second half of medical. We put on multiple cultural talent shows, different bone marrow drives, and it was overall a really great way to involve both medicine and kind of my cultural background in a way that was meaningful to me. I had med school on MASH day in fourth year. I ended up matching at Thomas Jefferson University, which is in Philadelphia, and I did end up choosing internal medicine. I had an idea that I wanted to do gastroenterology at that point, but I wasn't exactly sure if I wanted to stay within general GI or if I wanted to do some subspecialty. One thing I did learn in the year kind of from college into med school coming into residency is that I really enjoyed teaching at all kind of levels, whether it was at the bedside with the students who were maybe more junior than me, or even tutoring or mentoring undergraduate students who were trying to figure out if medicine was the right field for them. And so I did enter the medical educator pathway within my residency. And that was a pretty dedicated way to look at how education is actually imparted upon different levels of learners. And I was fortunate to kind of use my psychology background in decision making and learning theory to really focus on how can we best help students learn. Residency, much like med school, is pretty busy overall. In internal medicine, we rotate through general medicine, so primary care specialties, meaning physicians in the outpatient setting who take care of all kinds of things, as well as specialty clinics. So different specialties, including cardiology, gastroenterology, which is my field at the time, liver disease, even pulmonary, all kinds of organ systems that I was able to rotate through. And I think the benefit of that is that you really get a very wide sampling of what is available. And during the 3 years, I had ample opportunity to kind of sample, and I really did enjoy gastroenterology a lot. Because I decided on that fairly early on, by the end of my first year, I knew I wanted to do GI. I focused on research, was actually really, really important for a lot of the internal medicine subspecialties, no matter which one you end up choosing. Just because of what my mentors were doing during residency, I focused on inflammatory bowel disease, so Crohn's disease and ulcerative colitis during my residency. And then I also focused on colon cancer screening in different populations, especially those who were underserved. And so that was kind of the bulk of my research experience. Definitely different than the medical school. And I think it was more so the clinical research experience compared to some of the basic lab science research I had done earlier on. It was a nice comparison, and I realized that I really did like clinical research much more than I like basic science or wet lab research, which is an important distinction to make because they do have very different paths. Going forward, my GI fellowship was actually a combined program between the University of Maryland and the National Institutes of Health. My first year was at the University of Maryland in Baltimore. It was a purely clinical year, so all those 12 months were seeing patients, different rotations, different sub areas of GI, and learning kind of the basics of endoscopy to do procedures, take biopsies, remove small cancers in the colon or the intestines. Second and third year of my fellowship was more of a research focus. And so actually, I moved from Baltimore a little bit further south to Bethesda near DC, where the NIH is. And interestingly enough, the year I started was 2020, so when COVID was happening. And so the NIH was in the middle of a lot of different clinical trials and some political backlash also. And so being in that environment was very interesting, somewhat turbulent for sure. My 2 years at NIH were divided between clinical work, which was about a third of the time, and a research focus, which was about 2/3 of the time there. Now, the interesting about the NIH was when I was working there is that the hospital is actually a research hospital. And so they really focus on diseases that are rare or not very well studied. And so the first year I had in Maryland really gave me the basics of GI disease overall. In the second and third year, I really kind of focused on rare GI diseases. And I thought that was a really great comparison. I got a good grounding in kind of the bread and butter of what a normal GI doctor would see day to day. But then I also got to focus on things that I may not have ever seen before. And having that exposure, I think, really rounds out your experience. And you learn a lot from rare presentations of common diseases and common presentations of rare diseases. Throughout this entire time, the 2 years and obviously onward, COVID-19 was happening. That affected a lot of our clinical education, both from a procedure perspective, because endoscopies and colonoscopies are what they call aerosol generating procedures. There was a lot of concern that if patients did have COVID, there may be potential for contamination or spreading of infection. So they're very, very strict protocols. And so I think our year for fellowship is very, very unique because we had to have very strict guidelines, and we had to make decisions sometimes without the appropriate information, because often we had to see patients that couldn't able to be seen in person. And so around this time is when telemedicine took off nationally. And I think we really focused on it at the NIH because we had a lot of patients who were immunocompromised, a lot of patients who were on clinical trials for different kind of immunotherapies or chemotherapies. And I learned a lot during that. Towards the end of my first year in Maryland, I decided that I wanted to focus on liver disease for a variety of reasons, which I'll talk about later. I wanted to have that focus, and because you have to make sure you apply on time, it's a pretty strict deadline and time frame. I decided early on, applied my second year. I was fortunate enough to get an offer from Mayo, and I decided to go there. I was really happy with my interview and the different individuals there. So moving on to kind of the ending of the educational process. I'm at Mayo right now. I've been here for about 5.5 months, a few more months left, and I graduated in June of this year. It's a very clinically heavy year. This year is very, very focused on liver disease, whereas the prior 3 to 4 steps have been fairly generalized. This year we focus a lot on patients who need liver transplants for a variety of different indications, and patients have liver disease from both very common diseases like alcohol-related liver disease or fatty liver disease, all the way to super, super rare genetic disorders. And I was talking to Michael about this beforehand, but as we go on in training in medicine, there's increasing autonomy you get as a trainee, even though you're still technically in training. The goal is to prepare you for when you're going to be independent. And since this is the last year of my training, there's definitely a sense of dread and excitement, right? Because I'm finally going to be able to do independently what I wanted to do for a very long time. But there's also that hesitation, right? You have imposter syndrome kind of creeping in and voices, on from the side saying, "Hey, are you sure this is the right thing to do? Should we ask somebody? Do you want to double check?" And I think that's completely natural. And I'll talk about imposter syndrome a little bit later. But this year has been really wonderful because I think it's the culmination of what I loved about medicine in one subspecialty, doing kind of exactly what I wanted to do. And I'm fortunate to be at Mayo that has a quaternary care center and a lot of different resources to help patients with liver disease overall. So I'm excited for the next few months. As I move on, that's where we start talking about things like faculty jobs and what I may do for my first job. A lot of this tends to be somewhat of an existential crisis. You ask anybody at the end of their training, right, their ultimate year of training, and no matter whether they're internal medicine, whether they're surgeons, no matter what, how many years they have and what they're doing in, the last year of training has some element of trepidation. Not only because you are worried about if you know enough and if you can actually help your patients and you're not just faking it until you make it, but really because this is the end of training, the training wheels are off and you really have to make some, kind of adult decisions, right? What do you want in your career? What does that mean? Traditionally, medicine has had three large categories of things that people can do, and individuals kind of choose as they want from these three aspects. So, three areas are clinical medicine, so seeing patients, taking care of patients, making sure their diseases are taken care of, whether you do procedures or whether you're a diagnostician and you do different tests and evaluations. A lot of that has to do with how well you work with patients, how well you can help them, and that relationship you build with them. The second big area people focus on is research, right? Clinical medicine is wonderful, but without research, it doesn't really advance. You need to focus on and understand what are the new ways to treat older diseases. Are there ways we can improve? What risks can we take within an acceptable range that will tell us, yes, this is a better treatment for a patient than something we tried for the past 30 years or so. And that requires a lot of investigation. It requires ingenuity, curiosity, and also patience. Things like this do take time, and I think that's an important part of medicine overall. The last area that I think is important is education, and I think everybody who goes into medicine has benefited in some fashion from people who have taught them, whether for a short amount of time or whether you've had long-term mentors. And for me, I think out of those three, education is the thing I hold most close to my heart. I think it's really important to teach the new generation of physicians who are being trained in ways that are even different from me, right? And I'm still in training right now. Things change every year, not just in terms of diseases and not just in terms of treatment, but they also change in terms of what people want, what their goals are, and how we can best help them achieve their goals. Medicine has transitioned from being paternalistic, dictating to patients what they must do, to really having a shared biopsychosocial model, and involving the patients in their care much more closely and intimately. And that requires a lot of nuanced training that may have been lacking, in the years past. Finally, a word on work-life balance. As I think about my first attending job and what it means, and trying to understand how different it's going to be from training, residency, fellowship. Um, this is probably, people often say that the best way you can, live your academic life is have a work-life balance. And I personally think that that's not the best way to characterize it. Um, I don't believe necessarily work-life balance, but I believe that you adjust that balance. It's more like a seesaw than really 50-50. Certain points your work will take up more of your time, and that's okay. And at certain times you prioritize things in your personal life much more than strictly work. And as long as all the bases are covered, as long as the patients are being taken care of, it's important to understand you are an individual and you cannot change the world, unfortunately, just by yourself. Um, and that's something I think I had to learn over time, that it takes resilience for sure to have success in a career in medicine, but you also need to know what your limits are. And that's more of an experiment in humility than anything else. And I say that only because physicians tend to be a bit on the arrogant side for a lot of reasons. And so I think that dose of humility is very, very important to understand before you step out into the world as an adult, as a attending physician. So with that, I'll step off my soapbox and I'll talk about overall lessons that I've learned through my medical education. Firstly, I think it's important to understand the difference between interest and osmosis. There's there are things that you're interested in that you like and that you want to pursue. Often, though, we don't think about those things. We more often work by osmosis, and what that means is we happen upon things, or people mention things to us that happen to be around our area of expertise, and we just dive into them because it's easy to go into it. That's not necessarily a bad option. It's a good way to get your feet wet and see what the lay of the land is and understand what is available. Um, as I went on, I think I tried to intentionally be much more in the former category, focusing on what I actually liked and not just what, my mentors who I looked up to, what they were working on. And it's okay to carve your own path and understand that you may be different than people around you, but I think that's a sign of personal maturity and development. And that leads very much into my next point, that you're going to change your mind a lot through every stage of education, all the way from high school, going to college, figuring out if medicine is something you want to do, then realizing something you want to do, but not knowing exactly what you want to do. The act of changing your mind, in my opinion, really implies growth. And so don't be afraid of having an opinion that is uh, evolutionary and really, really affected by new things you learn, because I think that's a sign of just being very emotionally mature. Third big point I think I learned is that serendipity isn't always serendipitous, and that it really helps to put yourself in places where you are going to be luckier than you would have otherwise. And what that means is understanding the concept of gateway personalities. And it's a concept I heard on a Tim Ferriss podcast a few months ago. And he talks about how if you are interested in something, you don't need to find every famous person in that area, in that specific area of knowledge or specialty or whatever you're interested in to be successful. You need to find one person who knows enough people that they kind of let you wedge your way into that kind of community. Um, Finding those people can take some time, and it's something that is not necessarily easily done. But once you do find somebody who's able to navigate you, that really helps. So, for example, when I was in fellowship, one of my mentors, Chris Coe, who was a gastroenterology attending and one of my personal mentors, helped me a lot during fellowship. He was able to connect me personally with a lot of different individuals in the liver disease community who I benefited from immensely. And I think if you find those people, hold on to them, thank them, be humble, and understand that they can really, really help you. Next point is ABC. This is straight out of business, right? Always be closing. And no matter what you end up picking up within your professional education and in your career, make sure you close the loop. You want to make sure you are known as somebody who can deliver, who can commit, who can finish something that they promise, right? It's always better to under promise and over deliver than vice versa. Finally, I mentioned this earlier, the imposter syndrome. Every level of training, no matter where you are, you're going to be surrounded by people who you think are much, much more intelligent than you are. And sometimes that may be true. Um, and they say that if you're the smartest person in the room, you're probably in the wrong room, right? And so imposter syndrome hits people really hard, really fast whenever there's a big transition in their career trajectory. And there are two things I would just want to focus on that. There's something called Occam's razor, which I'm sure everybody has heard of, which is a very common idiom in medicine, which says that the simplest explanation or the most parsimonious explanation is probably why the patient has a disease. So if you're able to come up with a diagnosis that ties together all the patient symptoms, that's probably the most correct diagnosis, right? Because the simpler it is, the more likely it is to happen. That works great in theory, but I think there are definitely times in medicine where the opposite occurs also. And there's an old idiom called Hickham's dictum. Dr. Hickam was a physician. I think he was chief of medicine at Indiana University in the mid 1950s, and his crude way of restating Occam's razor is that the patient can have as many diseases as they damn well please. And so while you try to find the simple solution to things in life, whether it's in medicine or outside of medicine, it's important to understand that things can be complicated. And it's okay. And you should recognize that there are other possibilities besides just the simplest one. So transitioning from those lessons learned to kind of overall tips for med school that I think are really important. Everybody who's a pre-med, pre-health, pre-PA, pre-pharmacy, pre-dental, they all get, so much advice about what is important to apply to these pre-health programs. And so I'm not going to reiterate everything. I think I'm going to just talk about things that I think weren't told to me when I was applying. The first thing is that medicine doesn't need to be inevitable. You don't need to have a package, a story, a personal statement, a CV that somehow wheels together a narrative that from the moment you were born, you were meant to be a doctor. I think it's important to show that you've explored different options, that you want to become a part of the medical community for X, Y, and Z reasons. So it's okay if you decided late, it's okay if you decided differently than your friends. It's okay if you take a gap year. All those things are fine. And actually they may benefit you more than they may hurt you. The second point is actually really important also, and I wish I had thought about this more during college, and that's that non-STEM knowledge is often more important to gain than scientific knowledge. When I was in college, I was a psychology major, as I mentioned, but I took a lot of biology courses, probably more than the prerequisites were for medical school. And part of the impetus for that really was that I wanted to make sure I was prepared when I did go to med school to have all that baseline knowledge. And now looking back, there's somewhat of a regret because I feel like I could have focused on other areas of the world in general that would have been beneficial to me. So those things include things that are wildly different, at least at face value, from medicine or kind of the scientific studies. So I would have loved to explore political science more, economics or international relations, or even psychology in a bit more detail, because you will get enough of that when you get to medical school, and you'll continue to get scientific knowledge at every level of training. But when you see a patient and you're in a room and they're sitting next to you, they're not going to ask you, what enzyme in the pathway is not working, right? In G6PD deficiency, they're going to ask you, how was your weekend, right? And you want to be a person as much as you want to be a physician. So I thought that was really important. And I wish I had thought about that a little bit earlier. Third point is probably the most important thing I'm going to say in my entire presentation, is that you should never underestimate the benefit of being honest and being kind, giving people a benefit of the doubt with the understanding that people have their own reasons for doing things. But when it comes to being a professional in medicine, honesty will always help you. No one's going to fault you for asking a question or making sure something's correct. Because the moment you make a mistake or you're caught lying, credibility does not get built up very easily. The last bullet point is kind of a side note, but it still applies to medical school. And that's that what should you ask for when you're interviewing for medical school? What are things that are important? In my opinion, it's really important to kind of focus on what are going to be the clinical rotations you have and what are the details of those rotations. I feel like when I was applying, I was really focused on what the curriculum was, what kind of system they had. Was it an lecture-based system? Did they focus on problem-based learning? Was it case-based? What was the makeup overall? And I think those are all really important things to consider because people learn very, very differently. More important than kind of the first part of med school, which is purely the kind of learning, is understanding what is going to be your clinical experiences. And now, depending on the med school, those clinical experiences sometimes start from day one, right? From your first month of med school, you can learn to see patients and have that as part of your education. So it's important to understand what those are, because really it's the clinical rotations that make you a really great diagnostician, make you a really great physician, make you a really great healthcare provider. Second thing is important is research opportunities, and this matters more for people who are going for certain subspecialties. There's certain areas of medicine that are more competitive, and so for those, to differentiate yourself, a lot of programs do use your research productivity and your activities as a marker of how interested you are and how well you know that area. And so inquiring about those remains very, very important. Finally, mentorship, and I cannot overstate this enough. Often people ask, or people say rather, it's not what you know, it's who you know. And I disagree with that a little bit. I don't think it's who you know. I think what matters much more is who knows you and who's able to vouch for you and take you from where you are to where you need to be in a way that's seamless and also gets you what you want, even if you don't know it yet. And we can talk forever about the difference between mentors and coaches and sponsors, and they all kind of have overlapping circles. But mentorship is extraordinarily important. Understanding you can have different kinds of mentors. You don't have to rely on one person um, to get advice from, right? You should have individuals who you focus on from a professional standpoint, who are your career mentors, who are your clinical mentors, who are your research mentors. People have very different strengths, and you want to make sure you have a tribe of mentors as opposed to just one individual who you kind of expect everything from, and they may not be able to give you that. So I think those are really important things to think about, not just when applying to medical school, but at every level of training. And so from here, I'm going to transition over to the clinical side of what I wanted to talk about today. I'm going to discuss 5 kind of large categories of liver disease, things that I see every single week when I'm in the clinic or in the hospital. These are liver conditions that are prevalent not just across the region here where I'm in Minnesota, but across the country and across the world. The incidence and prevalence changes obviously based on the geography and the demographics of the population. But these are very, very commonly encountered. So I'm going to go through them one by one, and we'll talk about what we can do for patients who have these diseases at the end. So let's first talk about fatty liver disease. This is the case that I'm going to talk about because we see it so incredibly often. All 5 of these cases that I'll present here are not actual patients. They're representations of patients I see very, very commonly. And so I tried to avoid any kind of identifying information in PHI. So this is a case of a 50-year-old gentleman. He has high blood pressure, has diabetes, has high cholesterol, the BMI of 45, which puts him in the obese category for the BMI, though there are better measures of your weight and your health. He tells me that he leads a sedentary lifestyle. He has a desk job, doesn't really move around much. About a decade and a half ago, he saw a primary care physician, and they told him that he had a fatty liver, and they told him to lose some weight, but really nothing else overall. Um, he comes to my clinic because his primary care physician did some routine blood work, and they found his liver tests were elevated overall. And so um, the example this is meant to talk about is fatty liver disease, which actually is a spectrum. And if you look at the right side, the diagram, it talks about the liver, which is normal on the left side. Over time, after a lot of injury from excess fat inside the liver, that develops into fatty liver disease. Over time, that inflammation continues, and you cause fibrosis, which is your liver getting really, really sick. The last stage of fibrosis is called cirrhosis. And so a lot of patients I see end up having cirrhosis from fatty liver disease over time. It does take a good amount of time for fat in the liver, to cause these symptoms. And the question always is, could we have done something earlier? What can we do about fatty liver disease, and how important is it, right? Is it something that I can just kind of brush off, or are we in serious trouble here? That's a really important question. So out of everybody who has fatty liver disease, only a certain portion actually get uh, inflammation. That's called NASH. And only a subset of those individuals get fibrosis, leading to cirrhosis overall. Um, we don't know exactly why certain people develop, further liver disease than others, even if they, for example, have the same weight and have the same kind of lifestyle and disease processes. There are certain genetic predispositions in certain populations that have a higher affinity for developing liver disease. But a lot of those things are really in clinical trials right now. We're trying to tease those out a little bit better. Back to our patient, he comes to you, and he's talking, and there are a few different ways we can kind of make the diagnosis. We can do some imaging, which requires ultrasounds or MRIs, and both those tests can really look at and quantify how much fat there actually is in the liver. Alternatively, if the diagnosis remains unclear, we can always do a liver biopsy, which I mentioned earlier. Hepatologists do those, but now it's becoming more of a radiology or a procedure. Unfortunately, there's not a lot of really good medications for fatty liver disease. There are certain medications that do work, but they don't really work that well. And so the practice to treat medication like fatty liver disease has kind of fallen out of favor. The mainstay of helping your liver that does have excess fat is really losing weight. The tough part is that you can't really target weight loss in the liver. It's something that you have to lose from your entire body, and your liver sheds fat as a consequence of that. We're fortunate here that we have a multidisciplinary weight loss clinic, and because having excess weight is a multidisciplinary kind of team approach, you need to have an understanding of why you're gaining weight, what is causing it, and how best to approach it. Traditionally, we tell patients, hey, it's probably best to lose weight, change your diet. 80 to 85% of weight loss ultimately does end up being diet. A lot of our patients do focus on exercise, which I think is really, really excellent. But exercise has very, very little impact on how much weight you lose. It's great for your cardiovascular health. It's great for making sure your heart stays healthy. But in terms of weight loss, diet is going to be the main thing overall. And so when we have patients who have fatty liver disease and we want to prevent progression into the end stage of liver disease, we're really focusing on weight loss strategies, and that involves dietary counseling, making sure people are eating the right food. The way produce is in this country, it's sometimes very, very difficult to have healthy foods. And I'm sure everybody has heard the concept of things like food deserts, where there's not a lot of access to healthy food, whether that's produce or whether that's access to livestock that's healthy, or organic, non-GMO, all that kind of stuff. It's really important to make sure the patients are well educated on that. Recently, over the past year or two, there have been more medications that used to be used only for diabetes that now have become popular for losing weight when you have liver disease. Uh, our viewers may have seen the articles in the New York Times about traditional diabetes medications like semaglutide, which is Ozempic, or medications in that category that are now being used for weight loss, and they actually work wonderfully well. The good thing about fatty liver disease is that if you lose anywhere from 10% down to even 7% of your body weight, you can actually reverse a lot of that stiffness and fibrosis. And so this is the mainstay of how we treat people who do have fatty liver disease. Moving on, we're going to talk about alcohol. And this is actually something in the past 2 to 3 years has exploded, especially during the COVID-19 pandemic. There was a study that came out about a year ago that said that alcohol use had increased over 40% to dangerous levels across the American population in the years of the pandemic. And the presumption is a lot of it is due to social isolation, both from a health quarantine perspective and things like transportation being limited during the early days of the pandemic. And so the patient I have here represents a pretty prototypical patient who I see, a 63-year-old gentleman who comes in from primary care referred because his liver tests were high. He says that he admits that he drinks alcohol regularly. Um, and interestingly, the limit for safe alcohol use for men is really 2 drinks a day or less. Above that is considered significant. And for women, because metabolism is different for alcohol, their cutoff is 1. So more than 1 drink a day for a woman is actually considered excessive. Um, there are different ways we assess people when they tell us, hey, I drink a lot of alcohol and my liver tests are abnormal. There are questionnaires like the Odyssey questionnaire that really kind of probes into how much people drink, how often they drink, how long they've been drinking. There are blood tests that are able to tell us how your liver has been damaged by by the alcohol, sorry, as well as how recently you've been drinking. Sometimes we have patients who unfortunately come to our hospital intoxicated or unable to get a good history from them. So a lot of these blood tests help give us some sense of how long they've had alcohol use for. And so the question always is, what do you do next? Right? You have this patient, they have liver that's not normal, and we want to make sure we help them overall. Similar to fatty liver disease, this also ends up actually being a multidisciplinary approach. Alcohol in general hurts a lot of different organs in the body. You can get inflammation of the pancreas, which is a major organ of digestion that helps you regulate your sugar levels. You can get gastritis or inflammation of the stomach. And alcohol has been implicated in a lot of different kind of cancers overall. So this patient, like a lot of our patients, we work very, very closely with our addiction psychiatry specialists to really not only tease out kind of the details of alcohol use, but figure out what the triggers are. A lot of people have specific reasons why they may have increased their drinking recently. Some people do have some genetic predispositions to have being damaged by alcohol more than others, even if they drink the same amount. A lot of programs that have liver specialists have connections to chemical dependency programs where we're able to plug our patients in, either outpatient or inpatient, to institutions that really help them get over this process. There are medications that can help reverse or reduce the craving for alcohol. And they're not used as much as I think we would like, but they definitely are there, and there are a lot more coming out of the pipeline in phase 3 clinical trials, and we're hopeful that that becomes another tool in our arsenal when we're helping these patients overall. Now, interestingly, um, there are a lot of patients I see who come in really high liver tests. They're in the hospital. They're pretty sick. We get them stabilized. They go home, and a lot of them, when they stop drinking, their livers actually get much better. They don't come back to normal, but they get much better. And so that shows us that a lot of early intervention when it comes to these liver diseases really does tend to help. I'm going to talk next about liver cancer and one specific kind of cancer called hepatocellular carcinoma, which is a liver cancer that's of liver cells specifically. You can have other cancers that come to the liver and other areas of the liver that can get cancer that aren't livers themselves. So this patient came in. She was a 57-year-old woman. She had cirrhosis. She's had it for a while. And she comes to my clinic and she tells me, hey, I've lost 40 pounds in the past few months. I'm really tired. I cannot get any energy to do anything. I have this really bad abdominal pain. Every time I eat, I double over. Sometimes I'm nauseated. I can't keep my food down. I vomit all the time. And so a lot of these things are what we call red flags or concerning symptoms that require a much more urgent workup than if a patient just came in and told me, hey, I have a little bit of abdominal pain, but it's not too bad. So understanding the difference between what is urgent, what is severe, and what's something that you can have a little bit of time and think about is an important skill you develop as time goes on in medicine. Um, for a lot of patients like this, we get abdominal imaging that includes CAT scans or MRIs. And for this patient, we ended up finding a liver mass. She had a 3 centimeter mass in the left side of her liver. And the interesting part about liver cancer is just kind of a fun fact is that most cancers, you need biopsies of some kind to really get a sense of what the cancer is, how you would treat it, if there's anything targeted that you can do. Liver cancer is one of the few cancers that you can actually make the diagnosis based on imaging. So based on how it looks like on the MRI, how blood flows into it, what things around it look like, you can actually make the diagnosis pretty easily, which is great because then people don't need to have a biopsy. They don't need to have, needles stuck inside them. When it comes to liver cancer, I always talk about three major ways we can treat it with our patients. The first is surgery, and that's the one people usually ask about. Can I just, cut that portion of the liver out and done? Other options do include liver transplant, actually. So we do liver transplants for liver cancer. We'll talk about that a little bit later in the PowerPoint. Um, there's a whole category of treatments called local regional therapy that are done by interventional radiologists. And these are procedures that either burn or freeze the tumor right kind of where it is overall. So these are really effective because they're very non-invasive and they burn them and freeze them through little wires going up through blood vessels. So similar to how you have cardiac catheterization, they take a wire through your groin or your wrist and kind of snake it up and navigate all the way to the liver. Same way we do that. You can burn it or freeze it. The last category of treatment is called systemic therapy, and this can be done in conjunction or alone with the prior two therapies. And this includes chemotherapy, which is traditionally how cancer therapies were thought to only be medication treated, right? You give chemotherapy, it kills the cancer cells, whole host of side effects that we have. Some of the newer medications are called immunotherapy, and that's actually a really exciting area of cancer research where it's separate from killing the cancer. What immunotherapy does is it helps your immune system really kind of rev up and attack the cancer itself. Um, it doesn't work for every kind of cancer. So you need to have certain kind of mutations in your cancer that is amenable to immunotherapy, but it was first piloted in melanomas and it spread to a lot of different kinds of cancers overall. And so they have their own kind of set of side effects and things that you have to deal with, but it's at least a new tool that we have to help our patients who have liver cancer. I'm going to move on to hepatitis C, which is one of the more common reasons people used to have liver transplants. And thankfully, hepatitis C, as of the past 5 to 7 years, is actually completely curable. If I was giving this talk about 7 years ago, I would tell you all about how hepatitis C is a chronic disease that has kind of questionable treatments. We can't get rid of it necessarily. And it's something that people struggle with often. As of 2011, that's when the first medications are called direct acting antivirals. They treat hepatitis C and actually cure them. This is a complete breakthrough for people who are interested in liver disease, because it's the first time a virus that causes liver disease really has the ability to completely get rid of the virus. And this was earth shattering. So this example is something we used to see much more commonly, and actually now we don't see it as much because a lot of the people who do have hepatitis C infection have gotten treated. So in this case, we have a 35-year-old woman. She has a history of intravenous heroin use in the past. She's been sober for a few years. They She was at her health insurance physical getting a new job. They did routine blood work, and she was found to have liver tests that were high. And so she came to our clinic, and we did a workup to kind of figure out why her liver tests were all janky. And she ends up showing that she has hepatitis C infection, and not only just now, but she's had it for a while and it just declared itself. This is not very uncommon. People do have this. When we have patients like this, we kind of assess for a few things. Number one, we want to see if the reason they got hepatitis C is still there. Often hepatitis C is transmitted through blood products or sexually transmitted. And this involves a lot of counseling for patients and making sure that if they have people they live with, that they are having appropriate kind of public health considerations, making sure that they're not sharing things that potentially could transmit the virus over. Aside from kind of patient counseling, the medical side of things, we focus on a few things. One thing is genotype, and that basically refers to the fact that there are multiple different subtypes of hepatitis C. So genotype refers to a subtype of hepatitis C. Um, and depending on what strain you have, what subtype you have, you get treated with different medications. The other thing that helps figure out how you're treated is what other disease processes you have, right? So if you have things like diabetes or kidney problems, some medications you can use. The final thing we often run into, which unfortunately is something that has not been necessarily remedied, and it's not a medical or clinical problem, but more of a social determinant of health, is really insurance coverage. Insurances are not covering all kinds of treatments for hepatitis C. And so often there's a lot of back and forth in terms of what medication the insurance provider will cover and how soon we can get that to the patient. And that often does end up becoming a barrier and a delay in patient care. A benefit now is that since 2011, it's been 12 years, almost 12 years, and there have now been medications that actually treat all the genotypes for all the strains of hepatitis C. And that's really wonderful because now we don't need to really be necessarily handcuffed by insurance companies to say, hey, you can only use this drug or this drug. A lot of drugs can do the same thing. The wonderful part about it is that you only need to be treated from anywhere from 8 to 12 weeks in most cases, and that's 2 to 3 months. And after that, you're actually cured. And you do get blood tests as follow-ups to make sure that the virus hasn't had resistance or come back. But it's something that's really, really great as a community we've been able to develop overall. Final category is drug-induced liver injury. And this is something that I think is very, very understated and underknown, even across the healthcare community overall. And so this is an example of a patient I've had very often in the past year or so. 33-year-old gentleman in this case, often a young patient, at least from what I've encountered. This individual had a recent COVID infection. They were sick for about 5 to 7 days, and afterwards they wanted to make sure they remained healthy. And so doing their own research and trying to figure out how they could stay healthy, they took some immune supplement over the counter. A few weeks after they started these supplements, they noticed jaundice, which is yellowing of the skin of the eyes, fatigue, a lot of energy loss, and some confusion. This patient was later admitted to the hospital actually because of how bad their confusion was. They just couldn't stay awake. And they had very, very high liver enzymes, and they were in what we call acute liver failure. In the hospital, a bunch of different things were tried. Because the patient was so confused, they couldn't answer their own questions. So we actually had to call the family to figure out what had happened. Were they complaining of anything specific, et cetera, et cetera. Now, ultimately, we figured out that it was an herbal supplement they were taking that caused liver problems. The difficulty with herbal supplements is that the FDA does not regulate them. And so because of that, there's no actual stipulations from a governing body saying, hey, you need to put only these specific things in these medications. Because there's no regulation, we don't exactly know what is in these supplements. So on the right side of a picture of turmeric, from Nature Made, not as a knocking at Nature Made. I put this picture up only because my mom swears by turmeric supplements. And so this is kind of one example of how supplements can be wonderful, but you need to make sure that they've been proven to not have any kind of toxicity. There are a lot of different ways these drugs can cause damage to the liver. Sometimes it can be direct damage to the liver, so it just hurts the liver cells themselves. A lot of times it can be because they trick your immune system, and your immune system thinks, hey, your liver is causing this supplement to kind of percolate and distribute throughout your body, so I'm going to attack your liver now. So your liver goes crazy as a response against your immune system. There are a lot of different ways that these supplements can hurt you. And the difficult part is that we never know exactly the degree and severity that a certain supplement will affect. Now, realistically, I think a lot of supplements are safe, but I think it's the unknown that's really difficult to kind of wrap our heads around. And the second thing is that people respond very differently, right? Everybody's metabolism is different, and because of that, you may process supplements differently. It's just because somebody did okay with it doesn't mean you necessarily will. Some of these patients do require liver transplantation because their liver is just so sick from all that damage from taking the supplement. In addition to over-the-counter herbal supplements and vitamins, sometimes you can get liver injury or liver problems from different drugs or different medications. That includes antibiotics. They're actually one of the more common causes of liver injury in this country, at least. Tylenol and overdose can definitely cause significant liver damage. A lot of the medications patients use for epilepsy treatment can cause liver problems. I already talked about herbal supplements. And finally, I wanted to mention Amanita phalloides, which is a subclass of mushroom that actually causes very quick liver failure. And so this is just something to be mindful of. We tell our patients, even if you don't have liver disease, be aware of eating kind of these wild game and mushrooms and flora when you're outside, because you don't know exactly where you're going to be eating. So all these 5 cases I presented were fairly sick patients. Some of them may end up needing a liver transplant. So I wanted to talk a little bit about what it actually means to get a liver transplant and how does somebody get there. It's a fairly comprehensive evaluation. The first step you got to figure out is, does this patient actually need a liver transplant, right? Is this something that will fix the problem? Are they symptomatic? And is their disease going to go away if they get a new liver? The second assessment is, and we talk to our patients about this in really great detail, is how thick is the liver? We need to figure out where it is on the spectrum. And I'll talk about that in a second. We use certain scoring systems that help us in that assessment. Third big thing we want to evaluate very, very closely is what other diseases do they have, and how will that affect not only the ability to tolerate the surgery and to tolerate the recovery afterwards, but is it something that may be a barrier to them getting the surgery, right? So some people have disease processes like diabetes, for example, or other uncontrolled diseases that are just so risky to do that the risk of the liver transplant is really kind of outweighed by continuing to live with the liver disease. In addition to hepatologists, who really kind of spearhead the process of liver transplantation, we work very, very closely with transplant surgeons to do the physical surgery itself, and are very instrumental in kind of the perioperative period to help patients get into the OR, do the actual procedure, make sure all the connections are tight and everything's working, and then the immediate post-operative care to make sure there's no bleeding, infection, or complication. We work closely with pharmacists also, and the reason for that is that there are a lot of medications you take after liver transplantation. So we need to make sure people aren't on medications that may interact with those new medications, and that they understand kind of the basics of medication administration. Our social work colleagues are extraordinarily important, right? We can do as best as we can from the medical side of things. But looking at social work is an important factor. And does the patient have a support system? Are they going to be able to make it to their appointment? Do they have difficulties with transportation? What can we do to help alleviate those purely non-clinical aspects that are very, very important to their care? And then for some patients, a lot of it with patients who do have alcohol use disorder and alcohol-related liver disease, psychiatry input is extraordinarily important to figure out this patient's ability to remain abstinent of alcohol and what they may need to really help them stay sober after the transplant. The evaluation is a combination of a lot of different blood work. We make sure we have a good idea what caused your liver problems. That includes also doing some imaging, whether it's CAT scans or MRIs. Some patients may require biopsies if we're not really sure of the diagnosis, because often the diagnosis can change how soon or how urgently you may need the transplant. I briefly wanted to talk about deceased and living donors, which you guys may have heard of. There are two general ways people can get liver transplant. One is that individuals who choose to donate their organs upon death, their organs are procured and they are given to the person who is highest up on the wait list. We'll talk about the liver transplant wait list in a second. And that is determined by how sick you are and how close you are geographically to where that individual is donating their organ from. A second option to get actually liver transplants is living donors. These are patients who require liver transplant, but they may not be sick enough to really have high priority in the wait list. And so some people have friends, family members who donate a portion of their organ. And so that's really interesting and really, really clever way to have somebody who's healthy and doesn't have any medical problems and donate a portion of their organ to the person who needs a liver. And so both those individuals actually go into the operating room together, next to each other. And the donor has a portion of their liver resected and is brought over almost immediately next door to the person who needs it. And both those patients actually have their abdomens open at the same time. And this has been going on for about 30 years or so. And we've found ways as a community to really optimize it, to really figure out how to make it safe for the person, because it is truly a very altruistic decision, not only to donate your organ after you die, but while you're living, because there are definitely risks with it. Um, so that's an important kind of distinction in ways we can have liver transplants. Finally, I'm going to talk very briefly about the selection committee. And this is the group of individuals who decide, will this patient need a liver transplant and how soon can we get them? It involves all the individuals I mentioned above. So the hepatologist, the surgeon, the pharmacist, social worker, psychiatrist, our nurse coordinators, all those people. The entire nation's transplant programs for different organs is headed up by an organization called UNOS, and they have very strict stipulations and regulations for how organs are allocated, because the goal is to make sure it is as equitably distributed as possible to minimize a lot of biases that may have been there in the past. And so there are a lot of moves now in the liver transplant community to make sure that we do not disenfranchise populations that may previously have been disenfranchised for access to liver care, including transplantation. Very quickly, I'm going to talk about the MEL score because I know we're coming up about an hour or so. The MEL score is an acronym. It stands for Model for End-Stage Liver Disease, and it basically is a score that assesses how sick your liver is. It ranges from 6 to 40. 6 is the lowest. That means your liver is not too sick. 40 is the highest. That means you need a liver transplant like yesterday. It's a combination of 4 different blood tests in a formula. And it used to be originally to see how sick your liver was, and now it's really transitioned over to how high you are on that wait list to get an offer for a liver transplant. The waiting time for transplantation really depends upon how sick a patient is, which is partially reflected by the MEL score. Blood type is also very important because the blood type of the donor and the recipient, the people who get the liver transplant, needs to match. And it also depends upon where you are in the country. So the map on the right side over here shows the latest breakdown of how the organizing bodies have distributed the country. The regions are split into 10 specific areas. Kind of a weird numbering system because it doesn't follow any specific pattern, because 11 is between 2 and 3 for some reason. I never got that. But you go pretty much around the country, and it's very population based. So you have to search in your own region first before you can get an offer from another region, depending where you are on the list overall. Priority for transplants, and this is gross generalizations, are given to children and patients who are generally sicker. Your MELD score sometimes does not capture the extent to which your liver is actually sick. So there are exceptions that can be made, and the details of that are beyond, unfortunately, the scope of the talk. I love to talk about it, but there are ways that your MELD score can be underestimating how sick you are. So there are ways to help assess your severity outside of the MELD score. So I'm going to finish off with this slide to kind of talk about the lessons I learned as being really passionate about liver disease and why I think liver disease matters. Looking at the 4 cases we talked about, fatty liver disease, alcohol-related liver disease, liver cancer, hepatitis C, and drug-induced liver injury, we can see that a lot of liver disease is preventable. And prevention, unfortunately, is something that healthcare doesn't necessarily emphasize, but it's something that does have a lot of benefit. You just see the fruits of that labor much later on. Um, there is a significant barrier to access to hepatology providers, and not just people who know about liver disease, doctors in general, but specialists in liver disease and transplantation. Um, Being in Minnesota right now, I can't tell you how many times I see farmers come from the nearby region, nearby state, who haven't seen a physician for 40 years. And they come in, they're like, hey, I started noticing my skin was turning yellow a few weeks ago. And it's really the fact that there's not enough healthcare access uh, in these areas across the country. Third reason why I think it's important to understand about liver disease is that you need to know what you need. And that means that better than actually getting a liver transplant, needing a liver transplant, is making sure you don't need it, right? There's no reason to put patients through surgeries that they don't need. And that's a very, very fine balance. And that's really where the art of medicine comes in. As I alluded to earlier, there's an immense healthcare burden when it comes to liver disease, causes cancer that can affect your quality of life in a variety of ways. Chronic liver disease overall can affect how you work, and that affects not just the individual, the family, and the community, but the nation at large. If you look at healthcare economics, it's a significant effect on how much liver disease plays a role in how much we fund healthcare nationally. And then finally, the details of transplant. Um, it tends to be something that is something not really well understood, and that involves both the ethics of transplant, people who may need more than one organ, so people who get livers and kidneys donated together because they have dual organs that are failing. Some of the ethical considerations behind organ donation are important to understand also to make sure we're equitable. That leads into the last point, social determinants of health, which um, is very, very clearly something that needs to be improved upon within hepatology, liver disease specifically. And that ranges anywhere from people who can't see hepatology providers, like I discussed above, people who don't even have access to telehealth and telemedicine, which really took off in the past 2 to 3 years. But if you're living on a farm in Iowa and without reliable internet access, it doesn't matter how much your doctor can offer you a Zoom call. It's just not going to happen. So those things are active areas of my interest and interest in people who are in the liver field. And it's going to be incremental changes. And I think those areas, these kind of 5 6 bullet points, are where um, we want to be focusing on as a field. To avoid things like getting to a transplant to prevent it. And so with that, I thank you guys all for your time. And I'm happy to continue.
Well, first of all, you blew us away with this presentation. This was fantastic. Going from the case scenarios and at the very beginning and in the middle, the advice. It really hit a chord with myself, and I'm sure a lot of other students listening in. What great advice. Like you mentioned, a lot of times we hear there's no shortage of advice, I think, in terms of at this point knowing how to pave your way around undergrad and all, but sometimes it's desensitizing. But this was definitely so insightful. So I do really appreciate the time that you took to gather this together, both for cases and the advice. Just to start it off, and as we go through, please, to those listening in, feel free to continue to drop in questions. We'll go through them for the next 20 minutes or so with Dr. Asif. But first thing is, you mentioned a long year path. You went from residency being internal medicine, then a fellowship in gastroenterology, and then even further with transplant hepatology. Before going to transplant hepatology, were you considering any other subspecialties, or were you set on that?
That's a great question. So, I went into my internal medicine residency fairly undifferentiated. I knew I wanted to do internal medicine, but I didn't know what area. And so I used my first year pretty aggressively varying my clinical rotations. And so I actually had rotations in the areas I thought I might be interested in. And that was cardiology, pulmonary critical care, and gastroenterology. And so, often it ends up being more of a gut feeling than anything really specific, right? And so I felt like, at least in my institution at Jefferson, I gelled the best with the gastroenterologist, and maybe it was just confirmation bias, but I really got their personalities. I got their sense of humor. I thought the way they did, and I thought, hey, maybe that could be me in a few years. And that will only reaffirm kind of later on, second and third year of residency. Um, Earlier on, I had thought about doing psychiatry or neurology because that's where my interests were in undergrad. And so I really enjoyed that research. And I realized, pretty quickly that even though the research aspect is something I really enjoyed, the clinical aspect, seeing those patients wasn't something that kind of got me excited or super interested. And so I kind of left that go pretty early on in residency.
You mentioned this specifically for your fellowship. With that fellowship, you mentioned the first year being at the University of Maryland, the next two being at the NIH. Is that a different sort of process just with going through that sort of fellowship in terms of applying there? Did you have to go through a different process?
Yeah, very good question. So a lot of programs actually have multiple tracks when they are accepting fellows for gastroenterology. And so there's a traditional track where you stay at one institution for 3 years. That's normally called a categorical or clinical track. And then there are kind of the other side of things where you have people who are interested more in research or education or certain kinds of research that may actually require longer training overall. So the track I was in was a research focused track. And so that's why the last 2 years were at a different place. It's actually through the same match process. It technically ends up being like a different code when you apply for the programs, but it's under the University of Maryland kind of subheading. But kind of like how ANCAP and AMC have different IDs, it has a different ID when you have the program itself when you end up doing the match, but it's the same overall process.
I also wanted to ask, now being a fellow at Mayo, a lot of people outside of Mayo and just as students, we hear how prestigious it is, how great of a institution it really is. But being on the inside of it, right? What would you say makes it that way? Are there any particular components to the structure of how Mayo is framed, or to the people there that set it at a different standard, or make others view it differently than other institutions?
Yeah, I get that question a lot. It's funny you ask that because that's something I had been wondering before I got here, and I was wondering, what makes it something that people are so excited about. And I remember when I was in residency, one of my attendings actually had done his residency at Mayo, and so I was talking to him, and one thing he often liked to say was that a system will only produce the results that it's really designed to make, right? And so um, what I took from that and how I kind of extended that into my experiences here and how I understand the way things are set up is that to have excellence in anything, no matter whether it's healthcare or medicine or politics, whatever, the institution needs to have a very, very firm, systemic algorithm and pathway for promoting that excellence. And so you can have the smartest people in the world, and that's not to say people here are not smart, they're extraordinarily intelligent. But I think you can get equally as intelligent people from any other hospital in the country and still succeed. And I think because they have cemented their pathway for how patients are taken care of extraordinarily well. And so what that means is that the breadth of specialties they have, the path they have for patients, even from an experience perspective, and I'm not going to ramble on too much, I promise, but it's something I think is actually important to understand because it reflects a lot about how you achieve excellence in life. And it's really about the systems you have in place, not so much the individual actions you do. The patient experience itself is it's amazing, right? You walk in and everything is tailored to you. They have their own app for your appointments. They have their own insurance program. They have their own pharmacies. And so when everything is self-contained, it's very easy to customize things. And they are very, very good about algorithmizing things across the hospital. So every institution within the hospital, every program, every department does things exactly the same way. And that homogeneity really promotes the culture of that.
That is a really good point. That is a great point. I gave me some insight that I never even thought about. But next question is, and you touched on this definitely towards the end, in terms of liver transplants, it's a topic of concern, like you mentioned. What are the biggest misconceptions that you see from patients?
Yeah, good question. So one thing that people, I think of often when we bring up the idea of a transplant is that every every problem of theirs will be solved by a transplant. And sometimes that's true, but there are a lot of things that even if you do get a liver transplant, you will have to work on hard. So I don't think it's the magic bullet that it's often perceived to be. Often people who have kind of chronic or end-stage liver disease are physically very weak. Their muscles are not as strong as they used to be. They're not moving as much. They are weaker physically. A lot of them require physical therapy. And so, as an example, people often think that, hey, I'll get a liver transplant, my energy is going to be back to 100%. I can do exactly what I want. And I think that's part of what the counseling we have to do early on when we see these patients to say, hey, we're going to put a new liver inside you, but the rest of you is still the same, right? Your heart is still the same. Your kidneys are still there, your muscles and things like that don't change. And they take time. And the transplant is a really big surgery. And that takes some time to recover from. And so setting those expectations, I think, is something I've learned to do earlier on in the process so people don't get either frustrated, upset, or disillusioned kind of later on.
Thinking about the subspecialty, transplant hepatology specifically, it reminds me of one of our earlier, a pretty recent one too, earlier specialties. It was a subspecialty of otolaryngology. So one of the questions we asked that speaker, and I wonder if it also translates to transplant hepatology, is being such a subspecialized area, do you find yourself limited in terms of the jobs that are open? So for example, you'd only be able to stick around at large academic institutions instead of explore other areas of the country in terms of your job search?
Yeah, that's a great question. That's been kind of the bane of my existence for the past 4 months while I've been looking for a job. So for people who want to remain in transplant hepatology, because there are some people who train in hepatology and they're like, hey, I'll practice as a gastroenterologist if they have that certification beforehand, and I'll just do hepatology as part of that somewhat, but not kind of in super great depth. Then most people who do a hepatology fellowship say, hey, I specialize in this. This is the focus of what I want my professional pursuits to be. By virtue of that, if you want to do transplant hepatology as a career, you really have to be, for the most part, at a large academic institution that has a transplant program. And the reason for that is that to do a transplant, you need a lot of different kinds of physicians and different kinds of healthcare workers. You need the hepatologists, the surgeons, interventional radiologists, pathologists who are experts in reading liver biopsies, liver pathology. You need radiologists who are experts in looking at liver imaging for a transplant, because a transplanted liver looks different than a native liver does. And then you need all the support staff. You need nursing staff who are very, very well equipped to deal with patients who have liver disease. Techs, MAs, very, very specialized skill set. So that limits you a lot. There are, I think, probably last time I checked, a little over 120 or so liver fellows nationally every year, 120, 130, depending on the year. And I'll tell you, there are not 140 liver transplant jobs available every year. So part of that is because you can only have so many hepatologists on staff at one time in a hospital. And so it definitely limits you. So you need to kind of have an idea of what you want to do. Now, thankfully, larger programs usually are in expansion mode. And there's a lot of push from institutional leadership to really expand transplant programs, because unfortunately, at the end of the day, the bottom line matters, and transplants do bring in a lot of revenue for hospitals. And so it's not as hard as maybe some other specialties may be. But you do have to make sure you look widely, because they're not available everywhere, and you may be pigeonholed in a city that you don't necessarily want to be.
Yeah, I'm surprised by that number. I remember the last subspecialty, the one I was talking about earlier, it was a couple hundred, but 120, 140, wow, that blows me away.
Yeah, it's crazy. It's crazy. And honestly, board certification in hepatology has only been around for the past 10, 15 years or so. I think I was talking to one of my mentors a few weeks ago, and he was telling me how there's probably under 1,000 board certified hepatologists in the country. And I think it's just because more recently becoming a much more kind of niche field.
Yeah, the numbers are surprising. Do you feel with that said that, I mean, you mentioned that the reason being that the numbers are this low is because of the resources and also the people power required. But do you believe that it's able to cater to the population or the number of people that actually need? Is it like a limiting reactant, I should say, to to speak in organic chemistry terms, to facilitate patient care, or would you say the supply of liver donors is the limiting reactant in that case?
Yeah. So I think, both those aspects have contributions to it. Last I checked, I think there were probably 11,000 people on the wait list annually, as of maybe a few years ago. And there are only 9,000 people who have the ability to donate organs, right? So there's like a 2,000 person delta every year for the past few years, at least, that does not get a liver transplant purely because there's not enough organs available. And that's really something that's happening in America. There are other systems for organ allocation, like Norway, for example. If you look at the European models, they actually have an surplus, an excess of organs. So they're a little bit more liberal than we are here in terms of allocation. They're not as strict. It's not as ethically fraught because they don't have to make those decisions who gets it and who doesn't, who gets to have more life and who would not benefit from it, which is a very emotionally charged decision and ethically very difficult to sometimes reconcile. But I think to your first point, the lack of providers is a huge issue. There's not enough people who are either interested in liver disease or have appropriate training in liver disease. And I don't think that's a comment on, providers or physicians in general. I just think that it's just so much information to know in medicine that you just can't know everything. And so to have people who are dedicated to liver disease is really important. We get referrals all the time from very, very well-known, reputed institutions that just maybe don't have the expertise that places with more experience do. And it's frustrating because a lot of patients can be served earlier. If they were seen earlier, they were treated earlier, things could have been prevented. And so there is a push nationally in a lot of our societies to help patients in those areas. And that includes a combination of training more APPs, so NPs and PAs, to help with liver disease, and to be kind of the next step in expanding access to care. There's another thing called Project Echo. You may have heard of it, where primary care physicians are able to network and telehealth in with specialists, and in this case it would be hepatologists, to virtually see patients in their office while they're seeing them. Patients who may not actually have telehealth at home or don't have Wi-Fi or internet at home. So they come to the primary care's office, see them for the annual. At the same time, they see specialists via telehealth visit hundreds of miles away. So there are a lot of models that are, trying to reconcile those gaps in healthcare. But I think we have a lot of work to do.
Earlier on, you talked about your undergrad and a few extracurriculars. Looking back, is there anything that you would change in terms of how you approached extracurriculars, which ones you got involved in, any opportunities around college? And a lot of our audience listening in, many are pre-health students, so I think that they could leverage that type of advice.
Yeah. I think I would have done a few things differently. I think when it comes to extracurriculars, I tried to be kind of very cookie cutter pre-med. So I made sure, I had the research box checked. I made sure I had my shadowing box checked, my, one long-term activity check, like all that kind of stuff. And I think sometimes I tried to do too many activities. And I think that doesn't let you really get deep into them, because I think longevity is much, much more important than breadth or variety, right? Going deep into 1 to 3 things and being able to talk about it in a way that is more than just like a 30-second soundbite, I think is much more important than saying, hey, I did 15 different clubs. But if you did 3 things, but you did them for 3.5 years super well and you were leadership positions, I think that's what I would definitely focus on. I did something like that, but not as much as I think I should have. I think the other thing I would have definitely done, I think I mentioned it earlier also, is you're going to be studying science, hopefully your entire life, right? In your professional life. And this is probably your last chance to get dedicated education and didactic on things that are not in medicine. Because I think the true sign of somebody who's intelligent and wants to really be successful is leveraging insights from disciplines that are not the primary area of their knowledge. So, for example, understanding other areas of knowledge much more deeply. So philosophy, economics, like I talked about, psychology, metallurgy, basket weaving, take your pick, right? Like something that's not in your area, that if you can draw a parallel, that will only help you expand your mind in medicine and outside of medicine.
Absolutely. And just to wrap up today's session, one thing that I think we've all taken notice is all of your advice is so reflective. I'm sure that you had to go through years of reflection to gather this together. And we appreciate you for bringing that forward. So for the students who are earlier on in their careers, relatively, right? Because it's a long journey, and undergrad is the first or second step to it. How do you recommend that they go about reflecting in the same way that so that they can develop um, real progress with personal growth?
Yeah, excuse me. I'm a big fan of introspection. I think um, knowing what you want professionally and personally is probably one of the most important things to do, and something that we don't really do. Um, Something that one of my professors told me a little while ago, and he was one of my research professors, and we were asking him, how can you be successful in academic medicine? And he used it more as kind of a stepping stone to, how do you be a good person professionally and personally? And so the way it relates to your question is his answer was that, he's like, do two things to really kind of promote your own self growth, mental mindsets, and understand where you're bad and where you're good. He's like, number one, read philosophy. And that's important, not in the base sense, but because it teaches you how to think. And a lot of times you just think very, very differently than you used to. And that takes time, and you have to kind of break certain heuristics and cognitive models and biases you have intentionally. And that's a painful process. You have to be comfortable with being uncomfortable. Second thing he said was, he's like, spend time alone, doing nothing and just thinking. And it sounds like, almost laughable at face value, but he's like, take a walk and just spend some time thinking. And I think partly it was a comment on how a lot of people often try to go through the day to distract themselves, right? So they're at work, you're on your phone, you're on TikTok, you're texting, you're snapping, right? You're doing all this kind of stuff. And he's like, really take some time and stop for a second and think. Um, and being with yourself can be very scary, but it can also be very, very fruitful. And those two things together, I think I really took to heart. So really kind of reading about how people think, meaning philosophy, and then being with yourself and being comfortable with spending time alone and being really focused in on that introspection. I hope I answered your question.
Yeah, just reflecting on it, I'm sure a lot of people have those times where they've seen benefits from those steps that you've mentioned, but it might have just been short intervals, not long term. And applying it long term, I'm sure it's exponentially that much more beneficial. So I really do appreciate that advice. And I wanted to ask specifically because the advice you mentioned during this presentation was so reflective. So I'm sure we'd really appreciate that advice from you in terms of being the same way, being reflective too. I do have some last reminders just before we wrap up today's session. So for those who are listening in, we have a quiz. For those who would like to receive credit for their attendance today of the shadowing session, you should take that quiz, pass that quiz, at least 6 out of 10 questions or more correct, and you'll be good to go. You'll receive the certificate. That certificate will be sent to the email inbox of the address that you list on the quiz. It's a Google form, so please be sure to use someone that you're comfortable with, preferably a personal Gmail or a personal Yahoo account. Just in case you don't receive that certificate in your inbox, please check your spam folder. If you don't receive it there, feel free to email us. Again, our email is community.h4h@gmail.com. And that quiz will be due next week at 11:59 p.m. Central Standard Time on Wednesday, February 22nd. For our next shadowing session, like I said, we're going to have a mid-semester break between now and March 13th. March 13th is when we're going to resume, and we're going to be joined by Dr. PreMed, who's a third-year diagnostic radiology resident at the University of Minnesota at 7 p.m. Central, the same time as typical. Again, Monday, March 13th. There's two ways that you can follow us on these sessions in general: Instagram and our email listserv. If you have any questions, feel free to email us. But those are all my reminders. I just want to give a big thank you to Dr. Asif for gathering this again. And to those listening in, let's hear some thank yous in the chat for him. He took a while to get this all together, and we really do appreciate it. But yeah, that's all. I believe you have a Twitter, right? Do you want to share that for any students who want to follow you?
Yeah, not a problem. Let me just put it up really quickly here. There you go. It's on the screen right now. Thank you, everybody, for listening. I really do appreciate it. Feel free really to reach out to me on Twitter about anything. I'm more than happy to help direct people, whether it's about medicine or hepatology or anything else.
We really do appreciate it. We really do appreciate it. All right. Well, I hope everyone enjoys the rest of your night. Thank you again, Dr. Asif, and we'll catch all of